Subcommittee will come to order. Welcome to the Ways and Means Subcommittee on Health hearing on exploring the use of technology and innovation to create efficiencies, higher quality, and better access for beneficiaries in our healthcare system. Over the last decade, Congress has passed several pieces of legislation that would expand the use of health information technology on a wide scale, helping to spur a wave of innovation and technological advancement. While these advancements have in part been utilized under meaningful use in the Electronic Health Record Incentives Program, there are a myriad of companies out there inventing and developing groundbreaking products that we do not yet see in federal healthcare programs like Medicare. The commercial sector of healthcare is utilizing many of these new innovations on a yearly basis to improve systems, medical facilities, beneficiary care, and collaborative care efforts. To date, Medicare has fallen significantly behind these efforts. We are here today to kick off discussions about the innovative and technological aspects of healthcare and explore how we can use already available and burgeoning technologies to increase efficiency, reduce waste, improve outcomes, and create greater access to care for beneficiaries in the Medicare space. What I hope we can talk about today is not about increasing or decreasing Medicare spending, but about using the existing dollars already in the program more efficiently, focusing on goals like giving patients more time with their physicians, clinicians, and more control over their health information. I've heard from providers back in Ohio about clinician shortages that are jeopardizing access for Medicare beneficiaries who need the care. That scenario is both unacceptable and untenable. There are better ways to deliver care if we can lift barriers and incentivize greater efficiency among all providers. Partnering with those who share these goals, including those who are already developing innovative products to create these efficiencies, will be a positive step towards bolstering Medicare's solvency. It is important to recognize what steps have already been taken to bring these technologies into the Medicare space. We can learn lessons from the implementation of the HITECH Act. Additionally, we can build upon the Medicare Access and Chip Reauthorization Act, or MACRA. Rather than create more bureaucratic layers, Congress should continue to remove some of the regulatory burdens and barriers, constricting advanced partnerships between technology and healthcare. During today's hearing, we'll discuss the role of innovation in the healthcare industry, look at how providers are leveraging the power of technology to cut costs and improve care for all patients, and explore how Congress can apply these lessons in order to further break down barriers rather than create them, to improve Medicare for beneficiaries and ensure that taxpayer dollars are being spent with these goals in mind. I now yield to the distinguished ranking member, Dr. McDermott, for the purposes of an opening statement.
Thank you, Mr. Chairman. Thank you for calling this hearing. In my opinion, it could be one of the most important hearings we've held during my time as ranking member on the subcommittee. Innovation will be central to our efforts to address rising healthcare costs. Currently, the United States spends 17.5% of our gross domestic product on healthcare, and it's still rising. And although the Affordable Care Act has helped slow that growth, we still have work to do. Innovation through electronic health records, telemedicine, and delivery system and payment reform must be part of our discussion. And so I'm interested in hearing from our witnesses about our progress in these areas. I'm also interested in hearing about the challenges we continue to face, because recent events suggest that turning an innovative idea into reality isn't always a straightforward process. We often point to accountable care organizations as an example of an important tool in our effort to shift toward a value-based system. If successful, they are supposed to lead to better outcomes at a lower cost. Care will be coordinated, unnecessary services will be reduced, and the patients will be healthier. But recently, last week, the New York Times reported on the challenges facing Dartmouth, an innovator that has struggled to make their ACO model work in practice. Although Dartmouth was improving quality and reducing costs, it found that the ACO was unsustainable and had to withdraw from the program. This is just one data point. You can't draw straight lines with one data point. But it certainly doesn't mean ACOs are failures. What it does mean is that there are questions we need to ask. We're trying to figure out where we're going as a country and how we can turn our investments in innovation into sustainable models moving forward. The process involves collecting data, trying new ideas, and learning from our experiences. My hope is that we can work together to do this in a bipartisan way. It hasn't always been easy. I know the Center for Medicare and Medicaid Innovation, for example, has become embroiled in partisan politics. That's a shame. The work that the Innovation Center is doing will help us become more efficient and achieve our shared goals of containing costs. I'm hopeful we can work together to support these efforts in the future. We have a great panel today, and I would like to hear our witnesses speak about the things they're doing to innovate and improve care, and I look forward to hearing from them about what works, what hasn't worked, and where they think we are heading. Because I know we can all agree that without meaningful action on cost containment, we will continue down an unsustainable path in healthcare in this country. I look forward to a productive discussion this morning, and I hope we can work together to find solutions. Thank you, Mr. Chairman.
Without objection, other members' opening statements will be made part of the record. Today's witness panel includes 4 experts. I would first like to yield to the gentleman from Pennsylvania who will introduce our first witness.
Thank you, Chairman. I want to thank Chairman Tiberi for his leadership in convening today's hearings to improve health IT and innovation in today's healthcare field and to generate greater efficiency in America's seniors, for America's seniors and patients, as well as saving U.S. taxpayers an awful lot of money and doing it in the right way. A leader in this field is Teletracking, a company based in Western Pennsylvania. In fact, it's in Pittsburgh, Pennsylvania. Teletracking's president, Michael Gallup, is testifying before us today to share Teletracking's success in transforming companies from a patient flow automation company to a real-time automated operations management provider. Teletracking's winning strategy has helped healthcare providers achieve broad operational efficiencies and cost savings. Mr. Gallup is leading Teletracking's transformative healthcare policies. I look forward to his testimony today. And on a personal note, Mr. Chairman, I'd like to just briefly talk about a man named Victor Phillips, who died March 21st, 1991. Mr. Phillips had open heart surgery. He was in the hospital, and after the event, he had to be taken downstairs to another room for another event to take place, or some type of a healthcare thing. I think it was dialysis. After they completed that, Mr. Phillips was on a gurney for almost 3 hours because they forgot where he was. So he laid on this gurney for 3 or 4 hours. Finally, somebody came by and said, "What is this patient doing here?" They said, "We don't know. He had a procedure done." He said, "He needs to go upstairs. He just had open heart surgery, and he's been disconnected from all his monitoring machines." They got Mr. Phillips up to his room, but by that time, he had slipped into a coma. He lived for about a week. Now, this is a guy who was a World War II veteran. He survived a battlefield, but he did not survive his time in the hospital. And I can tell you that Mr. Phillips at that time was 77 years old. I knew him for about 10 years. And the way I met Mr. Phillips is he was the father of my wife. And I watched as he lay dying and thought, if somebody had known where he was, this never would have happened. Teletracking is a type of company that says this isn't going to happen anymore. We're doing it more effectively, more efficiently. And I tell you what, there's not a day that goes by that I don't thank the private sector for coming in here and telling us how to solve problems. The solutions are there with you. You've done great work. Chairman Tiberi, I mean this sincerely. Thank you so much for bringing this hearing up. And I really wish I could go back in time to see my father-in-law again. And I'm sure I will see him again. But it was really to sit and watch that man after going through open heart surgery and then get lost, not because he wasn't able to survive the surgery. He was lost somewhere in the whole system. So, Mr. Gallup, thanks for being here, and thanks for all of you being here. You do great work, and we look forward to your testimony. Thank you, Chairman.
Thank you, Mr. Kelly, for sharing that story. I'd now like to yield to the gentleman from Oregon for our next introduction, Mr. Blumenauer.
Thank you, Mr. Chairman. My introduction is not quite as dramatic as my friend from Butler, but it is no less heartfelt, welcoming Jared Short. Cambia is headquartered in Portland, Oregon. It's a collection of companies. Jared at one point managed their 7 health, I can't keep track of all of them, 7 health insurance plans for the 4 Northwest states. But most recently, he's been focusing on areas of innovation, technology. They have services and technology, and Jared, as the Chief Operating Officer, has been focused on that. I have been pleased to work with this company, with people who are there, who are committed to the same sort of collaboration that my friend from Butler referenced. It has helped me in my service, and I think we've been able to add some additional benefit for the legislative process, and I'm looking forward to Jared's presentation today, and I think you will find it informative. Thank you, Mr. Chairman.
Thank you, Mr. Blumenauer. And finally, I'm going to recognize Mr. Kine from Wisconsin to introduce our third witness.
Thank you, Mr. Chairman. Mr. Chairman, I want to just especially want to welcome Dr. Long. He's the Chief Medical Officer and Vice President of Systems at Theta Care in Wisconsin. It is the third largest healthcare provider in the state of Wisconsin. I believe still the largest employer in the northeastern part of the state as well. And one of the leaders in affordable care organizations, the coordination of care, one of the lowest cost, highest quality providers we have throughout the nation. I've had, on occasion, a chance to stop by and visit Dr. Toussaint, the team there, and seeing the work up close, what they're doing. And they're really pioneering a lot of interesting, innovative programs, especially in the so-called super utilizer category that I'm sure Dr. Long will touch upon a little bit, hopefully in his testimony. I know he did in his written testimony. And it's one of the great challenges that we face, the fact that 20% of the population is consuming over 80% of the healthcare expenses, and how do we provide better coordination and quality of care at a better price for that high-risk population to begin with. So on behalf of our state, we're very proud of the work that Theta Care does, and Dr. Long, welcome to the committee today. Thanks for being here. Thank you, Mr. Chairman.
Thank you, Mr. Kine. And finally, I'd like to recognize Paul Black, the Chief Executive Officer of Allscripts. He'll be third on our panel today. We welcome all 4 of you for this innovative hearing. Mr. Gallup, you're going to go first, and it's great to see you again. We had a great visit at Ohio State, and my friends there are excited to work with you and have seen great results because of the work that you've done. So you are recognized for 5 minutes. Thanks for sharing your story with us today.
Thank you, Chairman Teaberry, Ranking Member McDermott, and distinguished members of the Subcommittee for Health. This is my first time doing this, and could be my last depending on how it goes, since my boss is sitting behind me, so be nice. No, it's our great honor to be here today and discuss how innovations to drive efficiency in healthcare can increase access for all, provide a better experience for caregivers at a lower cost. Each year, nearly 2 million patients walk in and walk back out of an emergency department because they are tired and frustrated of waiting. Millions more find themselves waiting more than 6 hours to get a hospital bed. Every minute of every day, an ambulance is diverted from its intended hospital. Yet there are 7 open beds for every 2 admitted patients. And why? Because there has been very little innovation or attention given to the logistical flow of patients, caregivers, assets, and materials. We are here today with evidence to show that complete visibility and automation of logistics for everything in healthcare, beds, operating rooms, infusion chairs, patients, staff, equipment, etc., through a centralized command center can fundamentally change access to timely care for beneficiaries and decrease the frustration for doctors and nurses that they're suffering today. Efficiency and automation is not about cutting back on vital resources or labor. It is, however, about eliminating the documented waste of nearly $1 trillion annually. There are vital minutes, hours, and even days wasted in the system because we lack the necessary transparency and automation that is so prevalent in other service industries. 46 minutes was just enough time to save the life of a new mother suffering cardiac arrest. That's the amount of time it took for her to be transported from a regional hospital's emergency department to an intensive care unit at Baptist Memorial Hospital in Memphis, Tennessee, following an emergency C-section. A physician made one call, to the Baptist Operational Command Center. This coordination center automatically set up transport and secured on-call specialists in the matter of minutes. Upon her transfer, the specialist saved her life. This is efficiency. What if that new mother's ambulance was redirected to another facility 15 minutes away, an occurrence that is all too common? We see a nation in which every health system is enabled by an operational command center, connecting care for doctors' offices to clinics, to hospitals, and beyond. One that places real-time data in the hands of clinicians and administrators. One that sees everything, beds, patients, staff, and equipment. One that serves as a care traffic control center. Dr. Joseph Underwood III at New York Presbyterian credits his coordination and command center with reducing the amount of time patients spend in the emergency department and allowing his doctors to spend more time with new patients. This is efficiency. Recently, a senior hospital executive called me shared two stories, one about a patient in rural Texas who had suffered a stroke in need of immediate care at the right facility. With one call, transport was on its way, doctors and clinicians were alerted, preparations were made in real time, and as a result, the patient returned to his family completely healed. Even at 95% occupancy, this health system has been serving 2,000 more cases just like this every month without any added cost. The same executive went on to share with this additional growth, his hospital system was able to serve thousands of community members without the means to pay for their care that they so desperately needed. This is efficiency. Efficiency is more than digitizing medical records. While crucial to the information sharing, medical records are not built to facilitate the movement of patients through a system. We are not seeking a handout, but we are asking you to consider the possibility of truly efficient care delivery system. Michael Zamias, the majority shareholder of Teletracking, has dedicated himself to it for 25 years, who, mind you, pays 100% of his employees' health care, and has invested nearly $1 billion into making healthcare command centers a reality. Through efficiencies and increased productivity, these care traffic control centers are self-funding. No additional taxation is needed. Through these type of efficiencies, we can serve millions of more patients by utilizing our underutilized assets, helping coordinate care so our doctors and nurses don't suffer from the wasted time. Less frustrated doctors and nurses are happier people. And by the way, those clinicians want this. I recently asked a nurse with a new command center what it meant to her, and she simply said, "It changed my life. I spend my time with my patients now." This is efficiency. And one last story, Teletracking was built on the premise that too much money created this problem and too little money will solve it. As an example, a chief executive officer called and thanked me for saving 308 jobs in his hospital as he eliminated costs from his system through the command center that allowed him to keep more clinicians and provide better care. This is efficiency. Thank you, Chairman Tiberi, Ranking Member McDermott, and members of the subcommittee.
Thank you, Mr. Gallup. Mr. Short, you're recognized for 5 minutes.
Chairman Tiberi, Ranking Member McDermott, and members of the subcommittee. My name is Jared Short. My name is Jared Short, and I'm the Chief Operating Officer for Cambia Health Solutions in Portland, Oregon. Cambia is a not-for-profit health solutions company that is committed to creating personalized experiences for people and improving the healthcare system. We are best known for creating the employer coverage insurance market 100 years ago, but our footprint has grown. We are a family today of 20 companies serving 80 million people, integrating technology to make healthcare simpler and more personalized. Cambia is making care simple for people by creating a consumer experience platform powered by technology. We are putting people at the center of everything and connecting the dots in healthcare that have not been connected before. With our tools, people can search for treatments. They can find out how much they cost. They can schedule appointments. Lastly, they can have drugs and medical devices delivered to their homes. And if they need help, we can help them with a human being. In my written testimony, we give examples of our health solutions and list our entire set of direct health solutions companies. For now, let me give you an example of one of our solutions, HealthSpark, a transparency tool that allows people to shop for healthcare services. It is its first of its kind platform, launched in 2005, that shows individuals the price and quality of healthcare services, allowing them to comparison shop and make appointments. Think of it like an Amazon or Expedia experience, but for healthcare. HealthSpark is a simple one-stop shopping experience. We have another solution called MedSavvy that helps people understand whether a prescription medication will work for them. MedSavvy provides information about the effectiveness and cost of prescription medications at a personalized level. It assigns each drug a letter grade, like a report card we would receive in school, so people can more easily compare one drug to another. Both patients and prescribing doctors can access the MedSavvy data that is used to determine the grades and post ratings and reviews about their own medication experiences. Another Cambia investment company, GNS Healthcare, is a company that collects patient data, analyzes it, and determines which treatments are the best match for individuals. GNS also has the capability to predict which patients are most likely to stop taking their medications. This process helps people have more success with their care plans and helps organizations lower costs related to medication adherence, diabetes, oncology, and more. At Cambia, we understand that healthcare is complex and it's personal, which is why we are focused on putting the consumer at the center of everything we do. Cambia's platform is all about making it easier for consumers to learn, decide, and pay for healthcare without intruding on the important relationship with trusted doctors. Elderly patients are frequent users of healthcare services. Today, there is an opportunity to expand these tools and capabilities into our senior population. We can help them save money, help the system save money, and it gives our seniors the health care they hope for and, quite frankly, they deserve. The Medicare program, by the way, can modernize its systems just like the private sector is doing. Beneficiaries can access the same capabilities that will allow them to live healthier and better lives. Cambia looks forward to helping members of this committee transition Medicare into the next generation of data analytics, healthcare coordination, and patient engagement. Seniors are just as eager for timely, consumer-friendly access to care. They do not want to go in and out of hospitals when they do not need to, and our system can no longer afford this level of inefficiency. Cambia is interested in partnering in a broader discussion about how to apply our innovations to the Medicare program to our seniors so they can have access to modern, high-quality experience. Thank you for the opportunity to speak with you today. Cambia Health Solutions would be pleased to share additional information about our platform. Healthcare innovation is a work in progress, and we stand ready to assist the subcommittee as it continues its exploration of how technology can improve healthcare and the experience for Americans and their families. Thank you.
Thank you, Mr. Short. Mr. Black, you are recognized for 5 minutes. Thank you for being here.
Chairman Teaberry, Ranking Member McDermott, distinguished members of the committee, thank you for the opportunity to share my perspective on the innovations taking place in healthcare. It's a privilege to be here discussing how technology is changing the way we care for people, improving access, efficiency, and quality while reducing costs. My name is Paul Black. I'm the CEO of Allscripts. Allscripts is one of the largest developers of health information technology. We develop electronic health records, precision medicine solutions, and information exchange platforms. Nearly 180,000 physicians, 2,700 hospitals utilize Allscripts solutions daily. We employ 7,000 people with offices in 16 states, including Illinois, North Carolina, Vermont, Georgia, and Massachusetts. Allscripts employees live in all 50 states. We are also the majority owner of NetSmart, the leading healthcare IT company serving the behavioral health and mental health and home health industries. Despite some bumps in the road, as can be expected in times of change, there's been a substantial progress in our industry that would never have happened had Congress not provided the impetus for ubiquitous adoption of electronic health records. These changes have disrupted paper systems that stood for decades, and the result is a new digital ecosystem of caregivers, software developers, and patients, allowing all to take a fresh look at how processes can be enhanced via automation. Fortunately, following disruption, there is innovation and opportunity. In response, we have engineered solutions that sit on top of this new digital platform. We are leading the way in helping providers maximize the extensive data stores that have been created within their electronic health records. Our clients use these tools to harmonize volumes of data from the individual's genomic story all the way up to the community's population health view. Allow me to give a few examples. Allscripts' DB Motion interoperability platform and information exchange and patient matching engine brings together clinical content from across the community into a single patient view. We create access to this data from both within Allscripts and other electronic health records, all in the clinician's natural workflow. We connect over 350 different data sources, including electronic health records developed by virtually all vendors, public health departments, and third-party claims systems. In fact, at the University of Pittsburgh Medical Center, the wait time for patient data decreased from as long as 20 hours down to 5 seconds, and the time physicians spent searching for information dropped from up to 40 minutes down to 1. Importantly, when a physician clicks the community view of their patient at UPMC, they make a different clinical decision 60% of the time. At Baylor Scott & White Health in Dallas, a 12-year-old girl was spared a second CAT scan when images from her initial ER visit were available later at another hospital inside of a different electronic health record. The ability to pull up these images prevented unnecessary radiation and saved her family more than $3,000. We recognize that tomorrow's healthcare networks aren't being built by our company alone. Since 2007, before ONC regulatory requirements, Allscripts launched an open approach to our electronic health applications, allowing third parties to integrate with our solutions. This has grown to a network of over 4,000 certified developers and providers using the apps that will exchange information over 1 billion times this year alone. Program highlights include an app that helps connect diabetic patient data directly into their doctor's electronic health record, an app that helps patients quickly and accurately provide updates before a practice visit, an app that helps providers connect patients to relevant clinical trials while still on site in their office, and an app that rapidly fills available appointments following a cancellation, avoiding lost practice revenue and creating accelerated access to care. Beyond our own innovations, our clients have also capitalized on this open platform, building solutions to deliver results to their patients. As I described it in detail in my written testimony, clients from Phoenix Children's, University Hospitals of Cleveland, Orlando Health have all built tools on top of our electronic health records to almost eliminate errors in medication dosing and administration, notably decrease rates of sepsis, and dramatically reduce readmissions, all of which drove material cost savings and improved outcomes. Allscripts was also the first in the industry to make significant investment in the area of precision medicine, aligning Congress' interest in this opportunity. We recently launched our 2B Precise solution, which will help caregivers proactively identify optimal patients for genomic sequencing and make the results available, understandable, and actionable at the point of care. The NIH will be an early adopter of the 2B Precise solution. We are early supporters of the Cancer Moonshot and among the first participants in the White House's Sync for Science effort, working with clients to contribute data to the NIH cohort of 1 million lives. There have been many more recent examples of innovation and improvements, both for providers and patients. We'd be happy to speak with any of you about our specific work in your district. Thank you for the opportunity to be here today.
Thank you, Mr. Black. Dr. Long, you are recognized for 5 minutes.
Thank you. Chairman Teaberry, Ranking Member McDermott, and distinguished members of the subcommittee, my name is Greg Long. I'm a family physician, and I serve as the Chief Medical Officer and Senior Vice President for ThedaCare. Thank you for this invitation to appear today and discuss how technology and innovation can be leveraged to improve access to care and deliver better care at a lower cost. It is an honor to appear before you today alongside this distinguished panel. As Mr. Kind had mentioned, ThedaCare is a non-for-profit, community-owned health system in northeastern Wisconsin consisting of 7 hospitals, 34 health clinics, serving 8 counties. We are the 3rd largest health system in the state, and we serve over 240,000 patients. Over a third of those are Medicare beneficiaries. ThedaCare has for many years dedicated itself to advancing information technology to improve the way our professionals treat and engage with patients, expand access, and provide better, more coordinated care. In recognition of these efforts, ThedaCare has earned the Most Wired Award for 15 straight years. ThedaCare is also committed to delivering high-value care, and to us this means delivering the highest quality in a highly efficient manner, thereby lowering costs for patients and the overall health system at large. We are early adopters in healthcare quality improvement, having adopted lean methodologies in our care since 2003. And we have developed an embedded culture of continuous improvement with our team members. Additionally, our CMMI Pioneer ACO excelled as the highest quality, lowest cost provider organization in the nation for each of the 3 years that we participated. And we are now excited to participate in the next generation Pioneer ACO. ThedaCare is a member of the Healthcare Quality Coalition, a national group of leading health systems, hospital associations, and medical societies that are striving to transition healthcare delivery to a value-based system. With that background, let me first talk about how we are managing our complex patient care panel. In our service areas, as in many parts of the nation, a growing percentage of the population is challenged by obesity, alcohol abuse, diabetes, high blood pressure, asthma, and lack of access to primary care. To meet these challenges, ThedaCare embarked on a pilot in 2014 to identify our most highly complex, sickest patients in our internal medicine population in Appleton. We screened with a database tool that we developed through our Epic EMR, a risk stratification module that's looked at 7,000 patients, and from it identified 600 of the most complex. After we identified those patients, we enrolled almost 300 patients in our team-based care model and identified a team which consisted of 3 care coordinators, 1 registered nurse, 1 clinical pharmacist, 1 behavioral health clinician, 1 nurse practitioner, and 1 medical assistant plus 3 part-time staff in the same disciplines. And this was a decentralized model where we put these practitioners right at the bedside in those clinics with the patient. As a first step in the model, each patient met with the care team, completed an initial assessment of medical, psychosocial, and other needs. A customized care plan was developed and specific goals were identified. Each patient received supportive services and intensive management, including chronic disease monitoring, management skills, behavioral health screening, psychotherapy, and other behavioral health care. Patients also received assistance in obtaining housing and other basic needs through collaboration with community organizations, including Levin, the United Way, the Aging and Disabilities Resource Center, and the Housing Authority of the Fox Cities. The team provided home visits for patients with special needs and physical and mental incapacity. Team members would also accompany patients to specialist visits for health literacy and evaluate them in the hospital when admitted to help with their post-care planning, minimizing readmissions to the hospital. The results from this first pilot were extremely positive. The percentage of patients with uncontrolled diabetes decreased from 12% to less than 4%. Improvement was also noted in the percentage of patients with controlled high blood pressure, which increased from 89% to nearly 92%. And the percentage of patients who visited the emergency department more than 3 times in the previous 6 months fell from almost 50% to just below 19%. And for those patients with severe behavioral health symptoms, they were able to decrease their symptoms from 49% to 18% for anxiety and 53% to 40% for depression. And included in your written testimony, I give the table for other specifics on those results. As far as technology goes, to improve access, we've incorporated e-visits. Patients now are able to consult with their ThedaCare primary care physicians on certain conditions, and for a flat fee of $35, and without having to leave work, a patient can get a diagnosis, prescription, and/or referral for follow-up with respect to 9 clinical conditions, and we're in the process of adding 11 more. And we have over a 98% satisfaction rate with our patients. We also have tremendous experience with telepsychiatry. We have had a shortage of psychiatry not only in our area, but is recognized also in the country. We had a psychiatrist within ThedaCare that for personal reasons left our area and was still able to manage 2,000 patients from Utah to Wisconsin using telepsychiatry, having set up a remote clinic in the same office and still sees on average 22 to 24 patients per day. Lastly, for technology, we're implementing a telestroke program, which, as you know, Stroke is much like a heart attack, and that time is critically important. So in our outlying hospitals in the rural settings, we can now connect those EDs with clinical specialists from our stroke and have clot-busting medication delivered within a few minutes as opposed to potentially hours. So again, in closing, from my perspective as a clinician, it's exciting to see the way that technology and innovation can transform care and improve outcomes for our patients. And of course, like other healthcare providers, we continue to be challenged with the traditional reimbursement of fee-for-service that do not always support technology and innovation care models. And for this reason, we will and have continued to explore payment alternatives like next generation and private payer contracting to better support these clearly improved models of care. Thank you again for this opportunity to testify.
Thank you, all four of you, for fascinating testimony. We've got a lot of member interest today. I'm just going to have two quick questions here. Mr. Gallup, I'll start with you. An opportunity to take a look at the numbers, your numbers, and the successes that teletracking brings to every facility it contracts with, and obviously had an opportunity to view what you're doing at Ohio State and saw that nerve center or command center, which was amazing. Is there a role for what you all are doing on the commercial side under federal health care programs, and do you have any experience with any government programs, and how can we utilize what you are doing for facilities out in our communities for Medicare, Medicaid, or other federal programs?
It's a good question. Let me start with one thing as we all have these discussions up here, which is the care teams and people in the hospital are amazing, right? They are working as hard as they possibly can to deliver the best care, and I just want to make sure that that goes on record. A lot of this is a lack of tools that, frankly, we provide to them. And to your question, yes, we have some experience. We are probably the best example is we're currently working with the NHS in England right now. There's a lot going on with them, and we've gone at that from a public-private partnership perspective. We're working with a group called NHSI, NHS Improvement. We found 3 different trusts over there that they are monitoring and that we're working in and putting this platform into place. And what we've done with them is created a 50-50 kind of investment model where they put in $1, we put in $1, and we invest in helping them get this technology and be able to help their patients. They, obviously, as you all know, they are publicly funded. Totally, and that causes some significantly different behavior in the fact of it's a total zero-sum game. There isn't a lot more money to go get, and they've found that the way to do this is they have an aging population as we do, and they've got to put more patients through the system than they have previously, and that's going to cost money. And so we help them see that you could get more patients through the system at the same rate. And that's what we've been working with them on. And we have a system, a trust there. I have to keep translating between their language and our language, so that we have a trust there that we're able to help get 10% more patients through at the same cost. And matter of fact, they even shut down units and we're able to get more patients through their system to show that this was the way to serve more of their people. So we could do the similar thing.
So for my colleagues, I was at Ohio State's Medical Center, the Western Medical Center, a couple years ago, and they had a challenge that many hospitals had, that they had not enough space, at least they thought, not enough space, and so they had people in the emergency room in the hallways. So I go back to Ohio State last month, maybe July, I can't remember, all runs together anymore, and Mr. Gallup was there. Dr. Retchen, the CEO, took me to this command center. And if you can think about going to a restaurant, this is how Dr. Retchen described it to me. So this command center has every room in the entire hospital in the command center. And I think green meant the room was empty, red meant the room was full, and orange meant it was being cleaned. So the fact of the matter is, in this command center now, they can communicate with the emergency room or the entire hospital, actually. And so if you're a doc in the emergency room, Diane, you can see on the board if there's a room that's being cleaned, that's going to be ready and when, or if the room that's empty, much like a maitre d' in a restaurant can look at a computer screen to see what table is empty or what table is being cleaned. And so the efficiency that you have brought to this hospital in Columbus has been incredibly important. So thank you for your leadership. Dr. Long, I've read a little bit about how your system has evolved over the years and how you've been cutting out the fat in the system. Kind of the same question I asked Mr. Gallup. Is there a way to apply this, and are there examples of what you have done through your experiences that could benefit Medicare or other federal programs?
Yes, absolutely. And really related to the last question, interesting statistic that we found just in our organization alone, of our 7 hospitals, we have 21,000 inpatient discharges. In all totaled, our ambulatory practices see over 1 million touches per year compared to 21,000. So what we really like to try to do is catch people before they even have to make it to the hospital. So in light of the shortage of primary care, we feel that our team-based care model, as an example that I shared, is a way to leverage clinicians working at the top of their license to be able to support primary care, which still traditionally is the touch point for these chronically ill patients. And just sharing the statistics I did, we feel that we at least have a model, once spread, can actually be as cost effective because we can pay for other caregivers not necessarily having to hire as many physicians managing larger panels of patients. And my future would be, can we get into some sort of a capitated model that's based on the risk of these patients, not in the old HMO way, but more customized for these panels. And certainly Medicare falls into that category. And I think our experience with the Pioneer would show that we were able to manage patients to the lowest spend per beneficiary, all while achieving the highest level of quality. So we think we've been able to do that for many years. So I think the key is, though, how do you match the payment methodology at the same time you're improving care? I think that's probably been the biggest barrier for most healthcare systems, is that as we continue to do the right thing for patients, we are currently cutting our own revenue and not being able to pay in a manner that I think would be most beneficial in the future. So I'm very confident that we can do it if we can sort of match payment methodologies as we make those improvements.
Great comments. Thank you. I will yield 5 minutes to Dr. McDermott.
Thank you, Mr. Chairman. Mr. Kelly told a story at the beginning, which, you'd say to yourself, how could that happen in a modern hospital with all this technology? I'd like to hear, I was involved with the surgeons in their application of a checklist kind of system that's used in the airlines. When a pilot's going to take off a plane, he's got a checklist of stuff he's got to go through, including out and going and walking around under the plane and looking to see whatever's under there. Tell me what is in place in your system that protects the quality of care for patients. I'm all for efficiency and saving money, but the bottom line, as far as I'm concerned, is what happens to patients. And what happens to Mr. Kelly's patient is unacceptable, and I wonder how you deal with that in trying to cut costs and cut people. How do you prevent that? Any one of you who can.
Sure. This is Paul Black. So one of the things that we try to do inside of our electronic medical records is provide a checklist set of capabilities that you're mentioning. The caregivers all are extraordinarily dedicated to the Hippocratic oath that they've taken, which is to do no harm. So there's a lot of people that are out there each and every day that are working as hard as they possibly can, and there are many cases performing miracles. So I always try to start with that description first about these wonderful people that are out there doing
I'm a physician, so I understand what you're talking about.
Yes, you do. And, they're busy, they've got a lot going on, and no one ever does anything to try to cut a corner that would cause any sort of avoidable medical error. There are checklist systems that you can have inside of the surgery suite, and there are bedside barcode administration. A lot of the errors that occur in the industry have to do with medication administration, in this thing you may have heard in the past about 5 rights: right bed, right patient, right dose, right caregiver, and right time. Those 5 doses, or those 5 rights, as it's called, are things that we also automate as part of our medication administration process, as part of the physician and caregiver order entry, and to complete that entire loop that's all monitored and checked by the computer.
In Mr. Kelly's example, you can have all those checklists, especially when you're going into an OR or whatnot, or providing drugs. Mr. Kelly's example, the patient got lost somewhere in the hospital. The hospital is a big plant, so that's exactly what we do. We know exactly where those patients are. We know exactly where the staff members are. We, in real time, say, this patient has been in this space too long. We can actually tell you if a patient has been in a bathroom too long and maybe have fallen down, right? These are the technologies that aren't out there in healthcare right now to let you know exactly what's going on, and it even counts in the clinics. So to the doctor's point, there's a lot more visits out in the clinics also, and these clinics could run more efficiently. We're working with a system, and I won't name the name, but they are very, very well known for being one of the most efficient systems anywhere. And they thought their clinics were running at 80, 85%. When we went in and put in these technologies that says, here's where people really are, here's what they're really doing, when they looked at it, they were at 35% utilization of all their assets, including the docs. And so imagine being a doctor, which you are, and you are being utilized at 35%. And you're told, you know what, if you did it this way, this way, this way, you can now do 30% more work.
Let me just follow up on that to ask you, if you have this system in place, who is monitoring and saying this person has been in the bathroom in their room too long?
The system will do that. The system will say.
Who does it tell? I mean,
it'll tell.
System's got to. There's got to be some people somewhere.
Yeah. It'll tell the nurse who is assigned to that patient. Hey, nurse, this is what's going on. If that nurse is too busy, it'll escalate to the charge nurse.
On her cell phone.
On their cell phone.
It'll monitor or where?
On a cell phone monitor. Exactly right. Both of them start to alarm and start to say this patient's been there too long. In all situations, you can send it to a pager, a phone. You can have it on a screen. You could have a audible alarm. You can do a lot of things to say this has gone on too long, and that counts for everything from that perspective, right? That counts from I got to get my patient from point A to point B, and I know how long it's supposed to take to get to point A to point B, and this is an emergency. How do I then help them get there? Does that make sense?
Yes. Thank you, Mr. Chairman.
Thank you. Mr. Roscom is recognized for 5 minutes.
Thank you, Mr. Chairman. Mr. Chairman, good job hosting this today and calling this. This is important work, and I really appreciate the perspective of all of the witnesses, and I'm learning things by listening to you, and I really appreciate your taking the time. Mr. Chairman, I have good news for you. You know what the good news is for you? The good news, Mr. Chairman, is that Mr. Blumenauer and I have been working on a bill that fits right into this theme. Let me briefly tell you about it, and I think you'll like it, and I think our panel will like it as well. And it has to do with this notion of using the technology that's already deployed at the Department of Defense, applying that into a common access card for Medicare patients, to go right at this question of fraud. And what Mr. Blumenauer and I are proposing is a pilot program, not a big rollout all across the country, but a pilot program to get at some of the waste and so forth and the actual fraudulent transactions that are being manipulated by criminals. This is, it is, so in the oversight subcommittee that I chair, the fraud rate and erroneous payments, last year was 12.7%. I just got a text from my staff that, hey, good news, it's dropped to 12.1%. So if you just do a quick back-of-the-napkin calculation, we're throwing away, literally throwing away about $60 billion a year, roughly. So there's some very significant work for us to do, and I commend this to your attention. So let me just ask a couple of questions. Mr. Short, you were talking about, in your opening statement, about HealthSpark and MedSavvy. On HealthSpark, that is the ability, I assume it's kind of an app or a place that you can go online and so forth. How do you navigate through cost comparisons? Because one of the things that I think my constituents find frustrating is you go to a physician, there's a procedure that's done, and we have created this current system where the two people that should know the most about the cost of the transaction, that is the physician and the patient, have no idea the cost of the transaction. And our culture basically says, if you ask about the cost of a doctor, that's almost an offensive question. Try that. Hey, doc, what's this running me today? And your doctor will have an ashen-faced look. Say, you got to talk to Mavis at the front desk. You go to Mavis at the front desk, she has no idea. So how is it that you have an idea?
That's a great question. The institutions of healthcare have created this mirage of walls where transparency isn't something that is an everyday occurrence in healthcare. And so what we established was we worked with 70 health plans across the country, and we took all of their provider registries, we took what their contractual rates are that they agree to with providers, and we serve it up in what we call HealthSpark, our company, that allows a consumer, a member of any one of those 71 health plans covering 70+ million Americans, to go in and do a search on their procedures, look at cost estimations, and actually look at what the cost is if they go to a particular doctor or a particular facility.
Okay, so it's calibrated based on who the provider, or who the healthcare provider is, or I'm sorry, who the carrier is?
Yes.
Okay. Time is short. Could I just ask you to contemplate, the four of you, and maybe give us some feedback later because we don't have time? Legislatures tend to lag real life. It's just the way it is. It's not an inherent criticism. Legislative bodies don't lead by and large. It's the nature of them. So we're hearing from you, you're hunting out ahead of the pack, and we're being urged, the theme today is we're being urged to catch up with you, which is what we should do. Could you give some thought to sort of blue skying us further out? Like, what's the next thing that we should be thinking of? What are the things that you're thinking of, you and your boards and so forth are thinking of, that are 5 years out and 10 years out, not just today, but that we should actually be broadening out? We don't have time for that now, but I'd be very open to continuing the discussion, and I know I speak for everybody here that is interested in this longer view. I yield back.
Thank you, Mr. Roscoe. Mr. Khan is recognized for 5
Thank you,
minutes.
Mr. Chairman. And I would just echo that sentiment. I mean, that'd be a perfect tee up for some future hearings to talk about next 5, 10, 15 years and what's on the horizon and what we need to be thinking policy-wise to coordinate with the tremendous innovation that's taking place. Because I agree with my good friend, Mr. McDermott. This is one of the more important and useful hearings that we're having this year, and inspiring too, because of all the incredible innovation that is taking place in the healthcare field. And Dr. Long, I'd be remiss if I eventually want to ask you a question about your participation, ThedaCare's participation in the next-gen ACO and the success that you guys have realized, because there have been some ACOs that have decided the risk-sharing component that's involved, it's not worth it because they've already been high quality, low cost for some time, and it hasn't worked that well for them, so they opted not to participate. But before we do, I think we've got 3 great revolutions going on right now in healthcare reform. One is obviously the build-out of the health information technology systems. You know, before the American Recovery Act, before ACA, we were deplorably behind the ball when it came to electronic medical records and the meaningful use and interoperability, our ability to start collecting the data so we know what's working and what isn't, and then disseminating that information and driving that back into the hands of doctors and patients so they can make good decisions with it. And we see a lot of that exploding right now. And of course, in Wisconsin, we've got the EPIC system too, out of Middleton, that has been doing tremendous work. So that's one aspect of the revolution that's happening. Another is the delivery system reform that we're hearing about today, a more integrated, coordinated, patient-centered healthcare delivery system that was long overdue. And of course, being from Wisconsin, we've got providers of care, whether it's Stata, whether it's Gunderson, the Mayo system, Dean, Marshfield, Aurora, that have been at the forefront of this revolution on delivery system reform for some time. And then finally, and I think the big one, is aligning the financial incentives the right way. So we are rewarding outcome, value, quality, and no longer fee-for-service and just doing more regardless of results. That was bankrupting us because right now we're on a race against time as a nation, whether we can get smart quick enough in the healthcare field before we grow too old. And with 70 million boomers about to enter retirement and join Medicare, it's a race against the clock. But Dr. Long, back to data care, the next-gen ACO model that you're participating in, because I've heard some criticism, especially for the higher providers, the high-quality, lower-cost providers, that there's not much incentive for them to be joining this program because of the risk-sharing component and the fact that they've already been hitting those marks for some time. Right. How has Data Care managed that?
Well, thanks for the question. And it gets back to what I said a little bit earlier. We were in for 3 years in the original CMMI Pioneer, and one of the reasons we got out is because we thought we had hit that ability to get some shared savings back. So to your point, when you are a high quality, low cost provider, there's not much left to be able to get in shared savings. And that's why we think the next step, and somewhat to the blue sky comment, is how do we then go from the current model and escalate that into more of a risk adjusted capitation model where the low cost providers can get a lump of money that they know they can make the necessary margin on, but still offer extremely high quality care. So that we got out of the Pioneer 2 years early because we were concerned about that very issue. Yeah. So it is a leap of faith to try to move to that next model, which there's a lot of nervousness about because of the old HMO days, but we think we can do it differently.
Now, Theta is also an 8-9 county northeastern region of the state too, which includes a lot of rural areas. And of course, right. I represent a large rural western Wisconsin area myself. But are there some unique challenges that rural providers are facing under the ACO model that?
Yeah, absolutely. And that's where I think we can connect with our community services. We put together a rural health initiative that actually we supported and actually had a nurse going out to farmers in their homes and being able to help manage. So I think there's a lot of creative ways that you can put other clinicians with primary care physicians and expand the reach. To Mr. McDermott's point, regardless of technology, medicine is still a pretty high-touch industry. And it was interesting in the New York Times just this past Sunday, they talk about the old-fashioned way of treating diabetes. You can connect and engage people with technology, but you still have to work on all the things that are barriers for them to receive care. So yeah. I think it's very fitting to sort of get back to the basics, if you will, and help people through their psychosocial issues, their depression, their anxiety. Yep. And we've shown that we can manage that population pretty effectively.
Also been at the vanguard of telehealth too, but I'm especially intrigued and excited about the e-visit program that you set up, making it easier for people.
Another way to get
electronic
access.
Communication to get prescriptions and feedback without having to schedule an appointment, waiting time, and all the hassle that goes with that. So that's something more that we need to be exploring, I believe. Thank you, Mr. Chairman.
Thank you, Mr. Khan. Mr. Smith is recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you to our panel for sharing your insight and expertise. Obviously, a lot of taxpayer dollars are involved in the subject matter here today, and I certainly want to do my part in making sure that it is spent wisely. Common refrain that I hear when I visit hospitals across rural Nebraska is that the providers and administrators are certainly proud of the equipment that they have, but they're also concerned about their inability to meet the meaningful use requirements, and that they can't even communicate effectively with other providers or hospitals. And small hospitals have expressed concern that after their upfront investment, they have to continue paying licensing and maintenance fees on their systems, which certainly can challenge each and every one of their budgets. Now, based on these concerns, I do have a couple questions, so if you'll help me out here. I hesitate to suggest a one-size-fits-all system because I doubt that would work, and I don't know of anyone up here who would support that. But how can we ensure that this technology, which has been purchased perhaps, can actually communicate one with another or even universally.
That's fundamentally what we do when I talked about our interoperability platform. I agree that the dollars have been spent, and that's one of the other the distinctions that we have as a company is that we don't advocate ripping and replacing electronic medical records. We say the investments have been made. If the record doesn't work, or if you have problems with your current supplier, or they've decided not to go for MU3 compliance, then you have a problem, go do that. But if you have one, make what you have work and have it be interoperable. And if your supplier does not have an open approach, then we will help you as a client get that data out. Everybody adheres to some level, to some form of standards. MU1 and MU2 guarantees that, so we can get the data, and I can emancipate that data, if you will, from the EMR if that needs to be done, and there's some sort of effort on the other side from people not wanting to make that available.
So are you suggesting that with relative ease, it can already be done, ease and or low cost?
It is not necessarily easy, but it has been done at scale with a lot of very large organizations and some very small organizations. I've got people as large as HCA that uses our solution, and we have a client up in Vermont, a small 50-bed hospital that's trying to connect to 45 different physician practices to make all the information in that community available to one another on 5 different electronic medical record platforms.
And I might suggest that facilities do actually get quite smaller than that.
Yes, sir.
And yet I sense they are burdened even more so with the requirements and the mandates and the costs and the hoops, I mean, in very remote parts of our country. Now, on the topic of cost and so forth, can you demonstrate that there's enough competition in place right now, that there's actually downward pressure on these costs? Because, I mean, talking to providers, I take away from them that they are concerned that their costs are just spiraling out of control in an upward fashion rather than a more competition driving down the cost.
Yeah, there's a lot of competition in this marketplace. There's over 450 different electronic medical record suppliers that have been certified by the ONC, and there's various different models for pricing in that regard. There's license models, there's SaaS models, which is a software as a service, and there's actually one of the companies actually offers the software for free. They make you look at advertising from pharma, but it is a free electronic medical record. So there's lots of different models that have been put out there. Over time, value gets displayed by what outcomes you're able to deliver with your client, and that's something we focus on very vehemently, which is we want to make sure our clients are successful in using these systems to connect, to transfer data, to look at it from a community standpoint, and then move that information once it's been analyzed back down to that caregiver so they can actually take action at the bedside, at the home, or wherever that might be.
Okay, thank you.
Thank you.
Thank you to our witnesses. Thank you, Mr. Chairman. I yield back.
Thank you. Mr. Blumenauer is recognized for 5 minutes.
Thank you, Mr. Chairman. Mr. Short, I was probably derelict in not mentioning one item here that I think identifies Canvia's person-oriented approach to sustainable healthcare, because we've worked with your company, your CEO, Mark Gans, for years on end-of-life care, and watching what you folks have done on so many different levels to raise awareness, help in terms of policy development, empowering patients, is deeply appreciated, and I think makes a big difference and illustrates your approach. I wanted to just delve a little further into one point you made in the course of your testimony, where you're talking about having mechanisms to help people take prescription drugs that have been prescribed, presumably filled. My memory is that about half of them really are not taken. Now, we can be concerned perhaps about some extraordinary predatory pricing mechanisms on behalf of a few drug companies that raise eyebrows, but this this stuff needs to be taken to have the transformational effect. What is it that you are doing that you think is closing that gap?
You know, in the space of pharmacy, it is probably the most, it is the one place where transparency in healthcare today is absolutely possible right now. And so we started an effort that we call Med Savvy. I mentioned it in my old testimony. If you think about it today, when someone goes to their physician and is prescribed a medication, a quarter of the time when they show up at the pharmacy, they do not fill it because they were not aware of the cost out of pocket. There's another significant percentage of individuals who do not fill that prescription because of the side effects that are described by the pharmacist. There's another percentage that get home and because that is in the back of their mind, don't complete it. And so we've done two things. One, with GNS Healthcare, through taking consumer lifestyle information by connecting with EMR claims data, by looking at just all of our claims data as an organization. We actually look and create predictors for which members, patients, consumers will not take their medications and will not likely show up at the pharmacy, who will stop 30 days later. And instead of try to create rules-based engines on the back end of all that and reach out to a consumer or to a member to solve the problem after the fact, we've worked to put Med Savvy in the hands of both physicians and the patients that essentially allows all those conversations to be offered up front when the prescription is being prescribed. And so when I describe the letter grades that we've talked about, literally looking at the effectiveness of medicine, which there's tremendous research on, to understand which drugs are most likely going to be successful, and then actually allowing the physician at that time, through the Med Savvy application, to understand what that member's cost is going to be when they show up at the pharmacy. So there are no surprises, because that is the point to have the conversation, not to create lots of hoops downstream. Now, in the event that a consumer has done all the things, or a patient has done all the things right to go home with that medication, through the work that we do in our algorithms with GNS, we do an outreach program, and this is where the human touch comes in because care is human. And we will have care managers reach out to patients that we know are at risk of discontinuing their medication, asking them how it's working, if there's any complications, so that we can reconnect them with their physician. So that's what we've started in 2015 and 16.
And what are the metrics in terms of the impact? How well does it work?
Metrics. So the metrics today are that we're in 3 pilots. We're in a pilot in the state of Idaho. We're in the state of Oregon. So they're both in pilot phases today. We're doing them with delivery systems. And the metrics today are that the physicians that are prescribing medications, a significant portion of the time when they're looking at that are actually having a different conversation with members, and we see an increase. It's early to tell you from a pilot standpoint what the actual metric will be, but today there's about 79% engagement in the conversation, which is where we believe it starts.
And do you involve pharmacists in this?
We do. Actually, we employ pharmacists that do the work on the development of the programs and services. But from that point, we actually are all about enabling the patient-physician conversation.
Okay. Thank you very much. Thank you, Mr. Chairman.
Thank you. Ms. Jenkins is recognized for 5 minutes.
Thank you, Mr. Chairman. Thanks for holding this hearing. We thank the panel for your testimony and for joining us. This discussion regarding the use and future of healthcare technology and its ability to drive down the cost and increase access for Americans is a key discussion. I think most people know in my home state of Kansas, we're one of the top agriculture and aerospace states. But what a lot of folks don't know is that we are a hub for health technology companies as well. And it is also a very rural state and has many residents that are unable to access needed care to their location away from a major city. And so one of my priorities on this subcommittee has always been to help folks in rural parts of Kansas get the care that they need more easily than they can today. So maybe my first question would be for Mr. Short. In your testimony, you touched on Cambia's investment in Carina and its ability to allow providers to extend their service area with virtual visits. How will that technology help folks in a place like rural Kansas get better access to better care and drive down the costs?
Absolutely. It's a great question. Telehealth today is a great extender outside of a traditional bricks and mortar setting in healthcare, especially in rural areas. There are pilots throughout the country. We have them in the state of Oregon, where rural county critical access hospitals are doing telehealth with their patients. That then enables a conversation to occur on whether or not they need to come into, if you will, Portland, a bigger city, for more care. When you think about access itself, I'll speak to just seniors. 6 in 10 seniors today have flip phones. 30% have smartphones and mobile devices. And of that, things like Skyping, online chatting are very, very common. When you think about seniors specifically when it comes to accessing care, and I think about my grandfather and myself, transportation is a significant problem to get to a facility to have care. I can remember being 16 years old, and my grandfather needed to get to an office visit, and I would get out of school to take him. And guess what? He laid awake all night, worried, concerned, am I going to make it? Telehealth, I will tell you, he's no longer alive. I wish we had Carina 20 years ago, because my grandfather wouldn't have laid awake wondering, is a 16-year-old grandson going to show up or not? And he could have done everything on his iPad. And they have iPads today, because his conditions, his chronic conditions, which are prevalent in senior populations, he didn't have to go in and be seen firsthand. So when I think of rural areas, and I grew up in a rural area, what a great opportunity to extend care. What a great chance to connect additional care extenders so that it can connect into EMRs, to pre-populate, so that when someone, a senior or a patient, ends up in a more critical care setting, all of that relevant information is there so that their treatment plans are holistic in nature and not point specific. So I think Carina is a great opportunity to extend that.
Great, thank you. Mr. Black, it sounds to me like the private sector is working really, really hard to solve this problem, exchanging information between providers that we've heard about for so long. Can you just briefly tell us more about the progress and information exchange and what you think Congress should be doing to increase adoption of what's working?
I think that there's an awareness component here that is startling to me, quite frankly, because a lot of the things that people talk about with respect to the interoperability standards, the issues with regard to interoperability have been solved. And I think that there's just needs to be a greater awareness of what is happening out there in the small areas as well as the large areas, meaning the very small rural areas that need to have the connectivity as well as the larger organizations. Unfortunately, there's been, hearings and other discussion about data blocking and needed discussions about that because that has occurred in the past. And I think because of some of these hearings, those issues have been removed, either behaviorally or economically, or in some cases, there's been, a way to, which I remind my clients if they have issues with it, a way to actually call a hotline and to report somebody that's actually, doing data blocking. So I think there's a lot of reports and a lot of data that are out there that would suggest that that has broadly been solved. I think that the work to be done through the ONC has also done a very good job, and the new rules on MU3 actually create another layer of exposure into electronic medical record. So if I'm a supplier of electronic medical records, the application program interface is a different layer by which somebody can get into, a third party can get into your record with permission, with security, et cetera, and pull data out. And that is a big component of what's inside the MU3 legislation that I think is very valuable. The other piece that's inside the MU3 legislation is very valuable is the ability for patients to get access to their data. And at the end of the day, I think this discussion has to center more around the ownership of the data is not a large company, it's not a for-profit company, it's not an electronic medical record supplier, it's not the physician, it's the person, it's the patient. And that's the person that should own it, and everything should be engineered around that experience. And I'm telling you, now with the digital platform, there's going to be hundreds of people that understand that this platform is digital and this platform is accessible through APIs, and there's going to be a wealth of new innovation that sits on top of this thing when we look out over the next 5 years. There's going to be blue sky efforts. There's going to be all sorts of wonderful things get created as a result of this new platform that this great country has funded in great part over the course of the last 4.5 years. Thank you.
Good questions. Mr. Davis, you're recognized for 5 minutes.
Thank you very much, Mr. Chairman, and I also want to thank all of our witnesses for being here. Dr. Black, it was indeed a pleasure to meet and have some discussion with you on yesterday. And I know that Allscripts has made significant investment in finding more effective approaches to treating diabetes, which in some of the communities that I represent has almost reached what I would call plague dimensions. Could you share a bit more in depth what it is that Allscript has been looking at in terms of this?
Yes, sir. Thank you for the question. One of the things that we have as a byproduct of all this process automation is the data. And so we have in our capability over 40 million lives of humans that are out there that we have de-identified the data, and we actually perform a fair amount of research. There are all sorts of tools that data scientists can use to look at data. I have a thesis, I'm going to go in and look for a problem, or I'm going to let the data talk to me, if you will. That's called machine learning. And what we are seeing with our 40 million people is when we've specifically looked at the diabetes problem, is there are 7 conditions, 7 items or data elements that are out there that are predeterminants of a future diabetic problem. And so what we're doing is looking for people who have those 7 preconditions, while they may not yet be a diabetic, that we are working with them through cell phone alerts or other ways to score them on a health score basis to give caregivers or just the person themselves awareness that they actually are trending towards a diabetic condition. So that's another use. We talked a little bit earlier, my colleague from Cambia talked about the predicting capability of before somebody becomes debilitized by something as horrible as diabetes. Some of it's genetically engineered, and you unfortunately chose your parents incorrectly. Some of it is preventable, and some of this piece that we're working on has a lot to do with what prevention we can do by the data that will show the actions that you can take to prevent it.
Thank you very much. Dr. Long, you also mentioned high blood pressure and diabetes as an area of significant interest. Could you share a bit what you've been working on?
Absolutely, thank you. Actually, to Mr. Black's point, I think this is a great example of where the technology and the high touch of medicine is still a great example. We are looking at with this team-based care model that these clinicians, especially the care coordinators, we have 150 complex care patients that are assigned to, by name, a care coordinator. So they literally develop a relationship. What the data does is gives that care coordinator real-time point of care, often, information that if you have a diabetic, where are they in the system? Are they potentially going to be admitted to the hospital? Are they high risk for ED visits? So we can actually proactively reach out to these patients, and oftentimes using technology in the rural areas, FaceTime, Skype, to interact with these folks and actually help them. Because what I talked about too, I didn't get into a lot of the details, but as most everybody knows, there's a lot of the psychosocial, behavioral issues that actually prevent these high-risk patients from staying healthy or getting healthy. So this is a great marriage of data and our care coordination function team-based care model to reach out proactively and help those patients lose weight, get on the right diets, and get their chronic illness under control.
Thank you very much. Dr. Black, you also mentioned a bit about clinical trials, and we know that there are some population groups that are reluctant to engage in clinical trials based upon historical acts that have occurred. Does Allscript do anything to try and convince any of these groups to become more proactive relative to clinical trials?
Yes, sir. We are very convinced that we can help people identify if they have a condition that they are suffering from, that your last hope has been exhausted, and you now need to look for an experimental clinical trial or to be, am I a candidate for a clinical trial that's out there? That is something that people have, they've somewhat changed their mind over time. If I'm sick and I've been to my primary care, I've been to my specialist, I'm not getting any better, what else is out there? What conditions do I have that are so unique that I'm not getting better? And that's why a clinical trial, for us to be able to identify for them a trial that's local, a trial that would meet the criteria that they are currently, the conditions that they have, the medications they're on, and the, even to the behavioral health component. Here's a multifactorial complex problem that you're trying to navigate as a human, and to match them up electronically with a clinical trial is something that the pharma industry is eager to do that, and many patients, once we show them the evidence and the data, will be extraordinarily happy to become a participant in.
Thank you very much, Mr. Chairman. I yield back.
Thank you. The gentleman from Texas, Mr. Marchant, is recognized for 5 minutes.
Thank you, Mr. Chairman. I think my fear with all of this technology is that our government programs, Medicare and Medicaid, either have rules or regulations, or there is legislation that is necessary to make it so that the doctors and hospitals can fully utilize these new technologies with these kind of patients. Can I get each of the panel members to talk about that? Mr. Gallup.
Yeah, it's a great question. What we see a lot of is a focus on the past. I really like the comment before where it said, "What are you going to do in the next 5 or 10 years?" When we even think of this idea of telehealth, telehealth has to be coordinated in a way, and that's kind of where we want to go 5 or 10 years from now, is how do you coordinate all that, right? So you can have a telehealth visit, but you might need to get them somewhere. How do you get them somewhere? Transportation is an issue. So how do you make that in real time and make that all easy? So what we're seeing more is, hey, we're so concerned about the past of meaningful use and all these pieces that's going on now, that we're kind of stuck in trying to get to that future. We're talking about, he said 60 billion in fraud. Well, we have a 200 billion in waste just from inefficiencies, at least, that's been documented. So how do we make all that work together? Our centers are seeing that we can help in the rural communities. 3,000 more patients on average are getting access to care that weren't at the same price, right? We're starting to see a day of length of stay decrease in these hospitals, but also that affects everything else. It means they're going somewhere else. And so as we see it, you're right, which is how do we get out of this? We're talking about the fact that we had all this meaningful use stuff and we're stuck in it. We keep talking about how do we move to that next level, like Mr. Black said, and say, let's start getting value from this. Let's start moving this forward. And these ideas of coordination and command centers that are bringing in telehealth, all the telemedicine pieces that are taking care of the rural communities in Texas, in one of your areas, is the greatest example of helping the rural communities and helping those hospitals that are small working together with large hospitals that I've ever seen. It's amazing, and at some time I'd love to share it with you because there's many patients and beneficiaries in Texas who are getting access to care that they wouldn't have had by all this coordination.
Thank you. Ms. Short.
I would just add, really move into a place where we allow incentives to drive the innovations. Certainly there are many capabilities that are coming to market, that there are rules and there are regulations that make it challenging, especially when it comes to programs like Medicare. What I would offer up is that because these are new, the rules aren't set yet, and we don't know necessarily how to think about how to approve new concepts that are coming to market. We have to ask ourselves those questions. We have to ask ourselves the questions on how should we regulate them? How should we allow regulatory processes to put in place safeguards at the same time? I think we have to rethink how we do that so that the innovations can get into the marketplace. And this is new ground.
Mr. Black.
One of the constituents that we have, like you have as well, is we have 45,000 physician office practices, small group practices throughout the United States. One of the things that they're worried about today is the macro legislation with respect to the reporting requirements that they're going to have on their end. And what I would hope is that as we pass this legislation and as we are monitoring and measuring the compliance with it, that we don't make the reporting burden such that a small group physician practice participant says, I'm out of here, I'm done, I'm going to retire early. I don't want that to be the last straw, if you will, that broke the camel's back. So great legislation, great capabilities, technology-wise, et cetera, that are in that it really will, I think, help expose this digital layer better that's out there. But we also need to make sure from a workflow standpoint, we don't add additional burden to that small physician office practice who is already very, very stressed today to take care of the patients that they have and to do the important clinical reporting. But for a small office, that's a burden that we have to be very, very careful about the tipping point of asking too much from a regulatory standpoint for these folks to report. This country's built, there's a lot of independent farmers, there's a lot of independent physicians that are out there, and it's a noun and a verb, as we all say with regard to these guys. If they're still independent after, the last 6 or 7 years, that is something they absolutely want to be, and I hate to have anything that we collectively have done force them to have to either quit the practice or I have to be employed by a large local organization, a large health system, or a large clinic practice if that's not what I really wanted to do.
Thank you. The pride of Paterson, New Jersey is recognized for 5 minutes. Mr. Pascal.
Thank you, Mr. Chairman. Mr. Chairman, panel's great, and thank you for putting us together. Our healthcare system is undergoing, I think we'd all agree, a very fundamental shift right now by revolutionizing the way we pay for and the way we deliver healthcare. The Affordable Care Act laid the foundation for building a healthcare system that rewards quality, outcomes, and smart spending rather than the volume of services provided. And I'm glad that the innovators are here today. The next step is promoting what I would consider further integration of innovative technology into the healthcare system. Health and medical technology has evolved rapidly over the recent years, which has resulted in, I believe, an improvement in patient care. I believe we must think critically about how to foster technology in order to improve the patient's experience. Mr. Short, one of your company's technologies, which you wrote about in your written testimony, the Care Merge tool, allows everyone in a patient's life, from the doctor to the insurer to the family member, to access information about the patient's care. Over the years, I've met with a lot of constituents, by the way, who have told me their stories about caring for family members and the hazards of it and the problems of it, the challenges. Can you briefly discuss some of the benefits that the technology your company has developed can have in supporting family caregivers? Very important. There's more and more of them, and possibly making a very difficult job a little bit easier.
Thank you. It's a great question, and I would say on two fronts. First, Congressman Blumenauer a few minutes ago talked about our palliative care end-of-life work. One of the places that we acknowledge is that palliative care is best between family members and physicians. So the first thing we did was we actually, through the Cambia Foundation, funded grants all around the country to delivery systems to actually rethink about the holistic end-to-end care, including how you bring family members into that process. It eliminates confusion, it eliminates waste, and it allows you to focus on outcomes. So we've done that through our grants. It's something that we are several years into now and is working very well. At the same time, we recognize that capabilities like Care Merge are necessary so that depending on where people live and where they work and where they call home, then family can be connected with the physicians. So in the case of Care Merge, we're actually working with acute care facilities who are working many times with frail situations and allowing everyone to be on a common page, if you will, about where a patient or family member's care is currently at.
One of the shortcomings of the Affordable Care Act was dealing with acute care and everything stemming from that. And we could have done a much better job. We tried, but it didn't work. Mr. Long, in your testimony, you outline a care model, ThedaCare, and using what couples team-based coordinated health care with additional support services and intensive case management for complex patients. That's not easy, I know that. That includes providing assistance with basic needs, as I understand it, like housing and life skills to manage stress, to manage anxiety, and addressing emotional support needs of caregivers, many times not even discussed. So in your experience as helping connect patients with these types of resources, would you consider that a positive impact on what we're talking about here today?
Oh, thank you for the question. Absolutely. As you mentioned, though, it is resource intensive, and I think that's where the challenge comes in, is how do we support the resources to decentralize what has typically been central care coordination, central social workers, and actually putting them where these complex patients are in the healthcare system. So we've had an incredible impact. And if you think about population health, I think of it, as three concentric circles. We have our clinic, we have our specialty caregivers, and then we have the community at large. We're probably remiss in not taking advantage of all the community resources that actually can help our patients quite dramatically. So that's a fundamental thing that we're focusing on to help leverage being able to care for them.
Thank you. Yield, Mr. Chairman.
Thank you. The gentlelady from Tennessee, Ms. Black, is recognized for 5 minutes.
Thank you, Mr. Chairman. I want to thank you for holding this very important meeting today, because it really does encapsulate the future of healthcare, the things that we're talking about here today. And so many times we argue across the aisle, but I think this is one that we can all agree on, that is the future of healthcare, and that we need to get behind and make sure that we are listening to people like you that are out in the field and are so creative and innovative. I want to say, Mr. Gallup, I'm really excited about your teletracking, because I'm an emergency room nurse who would call the floor and say, I have a patient ready for you, and they'd say, that bed's not ready yet. And you'd call an hour later and they'd say, that bed's still not ready yet. Boy, the thought that I could look on some screen and say, wait a minute, there is a green light there, so I'm bringing the patient to you. It's exciting. I think, Mr. Chairman, we probably ought to take a road trip so we can see all this technology actually working. So I'm all in for that. One aspect, a major aspect of health IT that I've been particularly engaged in is the telehealth. And I know that Ms. Jenkins started to talk about that, and I've worked very closely with one of my colleagues here on Ways and Means, Mr. Thompson, on this topic. Early this year, we introduced a comprehensive bipartisan, bicameral piece of legislation, once again showing that this is an issue that both sides care about. The bill called Connect for Health Act was endorsed by about 100 organizations from all over the spectrum in healthcare. It actually showed by a study that was done by Avalier that you would actually save about $1.8 billion over 10 years if we were able to put this into place. And Mr. Short, you talked about how you wish that your grandfather would have had access to some of this kind of telehealth that would have given him more assurances, and as having two parents that are 91 years old and seeing what kind of technology is there and available for them is exciting. But it's got a lot of barriers there. And until this comprehensive bill actually is able to be passed, what I'd like to ask of you all, in particular looking at remote patient monitoring, which is one that's really near and dear to my heart, because I do have a rural district where I know this would really help, getting patients 45 minutes to an hour and a half to a facility is very, very difficult on windy roads, especially when they need to be seen several times a month or whatever by different practitioners. What I'd like to have each of you talk about until we can get to that point where we can pass comprehensive legislation, what are some of the small but constructive steps that we could take today to begin this process of putting in and expanding life-changing telehealth services? And Mr. Long, if I can start with you, since we seem to start at the other end, and just go down the aisle, and I know I don't have a lot of time left. So, Mr. Long, briefly.
Yes, thank you. Well, I think as I mentioned both in my verbal and written testimony, the things aren't really that complicated that can get us a lot of leverage. So whether it's the simple things like a low-cost e-visit to the very complex telestroke, it's all about keeping people where they are and not having to have them travel. Interestingly, I found in some of our rural areas, though, one of the simple barriers is that people are still on dial-up internet. And it was somewhat surprising to me that there's still pockets of our remote areas that don't have the luxury of the high-speed internet. And I know there's some talk about how can we change that, but I think the technology exists, and I think providers and patients are eager for it. So some of it's just kind of fixing some of those infrastructure
Get
pieces.
CMS to agree to pay for it. Mr. Black.
I think that there's been a lot of discussion about telemedicine and the fact that people haven't been paying for it. I think a lot of innovators have bypassed the payment component. Obviously, my folks to my left and to my right have actually figured out a way to do that. And the dollars that people spend on a visit, whether it's a consumer or the practitioner, they quickly get past the I got to bring the patient in order to see them in order to get paid, if in fact they're taking care of the patient in the way that they want it, or it's some sort of financial risk for them. There's lots of different ways you can connect to these people. The wearable component as well is another thing we haven't talked about today. When you talk about remote patient monitoring, that's a big piece. You can connect that to the caregiver or some sort of central facility. There's a lot of clients that are out there that are doing that today in a hub and spoke environment. The issue, though, I've got a brother who farms, I've got uncles who farm, grew up in Iowa, so I know a fair amount about what it's like for people that don't want to get in a car, that are scared, they don't want to go to a big city. When they get there, they're lost. They don't like it. And so I've been actually just, through the years of knowing what is out there in the marketplace, I've also have been having some preliminary discussions about how about repurposing some of the room inside the ASCS office. There's one ASCS office in every single county in the entire country. They have broadband, they got this, they got that, and it's a familiar place. People like the ASCS office because they know that's where people have historically given them money, they go for education, et cetera. And you could have a quick clinic perhaps there, and you might have a place where you could go plug in to get monitored or have your televisit at that facility if you don't have broadband at home. We're not going to get broadband in the entire country like we put the Rural Electricity Act in the 1930s. That's not going to happen for a while.
Well, thank you, and I know I've run out of time, so Mr. Short, Mr. Gallup, if you have other suggestions, would you just jot them down and send them back here to the committee? I certainly would appreciate that. Great suggestions.
Thank you.
I yield back.
Thank you. The gentleman from Minnesota, Mr. Paulson, is recognized.
Thank you also, Mr. Chairman, for holding the hearing. This has been a great panel, very interesting. And we talked earlier about and heard some comments about the legislature and Congress lagging behind innovation. It's interesting because a technology entrepreneur once said that innovation is the ability to challenge authority and break rules. And as a result, there's often this conflict between what government does and what innovators do. Government, of course, makes rules, and innovators are all about breaking the rules to create something new. And innovation, when it's happening at such a fast pace and rapid pace, if we're not paying attention, if government's not paying attention when, where, and how this innovation is happening, we're missing out on the opportunities. I should just ask, I'll start with Mr. Short, but others may have comments. Just from a cost perspective and the challenges we have within Medicare, where there's so many regulations, for instance, and what can the Medicare program be doing or to collaborate better with the private sector, for instance, to support better engagement, to have more superior results, or vice versa? How can Medicare adopt what the private sector might be doing in this respect as well?
It's a great question. Medicare has the ability and is frequently a significant influencer of care practices that are adopted across this country. And so to the extent Medicare in rural setting allows for innovations, even on a pilot basis, to be launched, deployed, that then again we could come back to and say, well, how should we think about rules and regulations that would allow for the further adoption of those capabilities, could really ignite greater levels of innovation when it comes to creating access. But most importantly, I think what we can continue to do, certainly with the amount of baby boomers that are aging into Medicare, certainly with cost challenges of Medicare, there's going to be tremendous institutional focus, whether it's about payers or providers or delivery systems. I would just encourage all of us to remember at the end of every one of these institutions is the patient or the consumer. And every one of us in this room have a story that we face when it comes to a loved one, a family, a friend. And so many times, if we will put ourselves in the shoes of understanding that situation, the innovation becomes bright and it becomes clear on what needs to be done. And I would encourage us at each and every day to do that first and foremost, because good things come from that.
Good. Any other comments off that?
Well, Medicare is the payer that everybody pays attention to, so you actually have the final, you have the economic club, if you will. And I think that the innovation that's been attempted through many of the different, whether it's the pioneer ACOs or those other structures that have been set up over the course of the last 5 to 10 years have been, I think, very influential in moving from a value-based or pay-for-performance or pay-for quantity to pay-for-performance methodology. We've got a lot of folks in Tennessee. The folks got together there to get 22,000 people to be part of their cohort. They got one primary care practice of 160 docs. Now they have 1,200 docs in the state of Tennessee that have gotten together through an interoperability platform, and they connect the information to take care of these 22,000 people in remote areas. And they are one of the top 5 in cost and one of the top 30 in quality in a state like Tennessee, where they have very little infrastructure in place. So there's a lot of innovation that's out there. I think that the structure that has been set up by Medicare is very valuable, and what's gone on with CMS on the payment side has been incredibly influential in the innovation that's been spurred. And I would just continue, I would suggest that rate of innovation and funding continues.
And Mr. Short, you commented earlier about chronic care, and I think obviously with the demographics, as you mentioned, 10,000 baby boomers retiring every day, chronic care management and coordinated care is the solution or the answer we need to focus on if we're going to be able to redirect dollars in a more cost-effective manner within Medicare. And Mr. Short, you said let incentives drive innovation. And obviously piloting, letting Medicare pilot things is a good way to do it. Anything else that we can do to actually incentivize innovation in the market?
I think there's always a lot to be thought of around innovation. I would say top of mind when you think about payment reforms that have passed to date and what's to come of that. I think continuing to see those through when it comes to how payers and providers collectively pay for service. I would say looking over the next 2 to 3 years, we talked about ACOs earlier today, in terms of how they perform and what's working and what's not working. Many times we will run on to the next innovation before we complete a current one. And I would say see through the current innovations as well and making sure that we deploy and scale some of them, because many of these have the ability to be scaled, especially as my colleague Mr. Black talks about the interoperability. I think there's tremendous innovations on interoperability to come in terms of chronic care management across a population.
Thank you, Mr. Chairman. Yield back.
Thank you. And last but not least, the pride of Butler, Pennsylvania, Mr. Kelly is recognized for 5 minutes.
Thank you, Mr. Chairman. I want to thank all of you for being here today. I think it's interesting. When I first ran for office, I was really trying to champion what we do in the private sector, and I had people constantly tell me, your problem, Kelly, is you don't get it. Look, the government can't be run the way the private sector is run. And I said, no, it's just the opposite. That's the antithesis. The private sector can't possibly run the way a government does. There's a handout. I think, Mr. Gallup, you provided it. I think here's where the rubber meets the road. It's not about the money that we spend. It's about the money we spend that's used inefficiently and effectively. So if you could, just kind of walk us through this, because I don't understand how people can indulge in deficit spending, not year after year, but decade after decade, and build a long-term debt that we know is going to sink our country, and say, the problem is we're just not extracting enough money from hardworking American taxpayers. These people are going to have to cough up more money to support our inefficiencies. So if you could, and I think this is really stunning, and this really gets to the thing, listen, is it about policy? Yes. But more importantly, it's about people. It is about people. Mr. Short, your grandfather, my father-in-law, this didn't have to happen. And it wasn't because they weren't spending money. It's because they were ineffective and inefficient, something we can't tolerate in the private sector. Well, you can, but you can't do it long because you go broke. Mr. Gallup, if you would, when I look at this, and especially if we look at, this is incredible, the United States of America. Now, Pat, listen to this. Out of 51 countries, the United States of America ranks 44th out of 51. And we've really worked hard. We've been able to beat Bulgaria, who's number 45, and we're just about catching up with the Dominican Republic at 43. And it is hard for me to sit here and look at who we are and what we've been and how we've led the world and everything. Gosh, we can put a guy on the moon, but we can't get him through the emergency room. We can invent the internet, but we can't get people through the hospital system. What the heck is wrong with us? But look at the spending. It isn't for lack of investment. Mr. Gallup, kind of walk us through this because this is stunning and it's also damning. It will ruin this country. If you can, this is incredible.
I think you just did a great job of it. So, I mean, I think the best thing I do is quote our clients, right? They know what's going on. And I think even the last Medicare question is very interesting, where what should we do about innovation? We shouldn't penalize people for coming up with innovations, right? Number one. So if someone figures out how to do something better, the first thing they're going to do is cut, right? And that kind of scares people. But as we quote our clients, they will tell you the money is in the system, right? They'll say that. It's exactly what you're saying. There's enough money in the system to get the patients through and give them the care that they need if we cut out the inefficiencies. To your point, we know that the CBO says 41% of the future of our hospitals are going to be running in the red. Why? Is it the funding issue, or is it the fact that we don't have the right models in place, that we don't have the right efficiencies put in place, and we haven't decreased the cost of an adjusted discharge, right? We have enough, and I think Chairman Tiberi saw this, right? There is enough bricks and mortars. There is enough out there to be able to go and do this. This isn't about cutting resources. You know, we have a doctor shortage, we have a nurse shortage, we have all these shortages out there. How do we fix that? Well, let's get them more productive. Every study you see out there, a nurse is 30% productive. The other 30%, we've got them stuck documenting. The other 30%, they are out there trying to, and I know that isn't at 100, so it's 33, but the point being is, they are out there finding stuff, wasting their time. So if we can take labor and help them become more productive, if we can help doctors become more productive and not doing things they don't want to do, we then get more patients through at the same price. And that's what we've proved in the NHS. That's what we've proved at many clients that will stand up and say this is working for them. We're seeing thousands of more patients, not just in the clinics, I mean, not just in the hospital, but in the clinics also. And that is what's going to cut the cost, right? If we can get more through at the same price, we have solved a lot of our problems.
Anybody else? Because you all have the answers. You have the answers. It's just, are we listening, and can we come up with a legislative fix to it? And I'm saying we have to do it, or we bankrupt our nation.
Mr. Kelly, I'm not sure if I'm allowed to say hallelujah, but I'm thinking it with your comments. But I think if you piece together all the great work that many organizations like these folks represent, I think the roadmap is out there. We all see the waste. We're all trying to improve it. My impression, even if you look at what the Pioneer has done, it's trying to look at where everybody is delivering care and try to do something that will work equally for everybody. And that's where you probably leave out those that are doing the best work and not trying to figure out how they could help create the roadmap that really needs to be the long-term blue sky. So I think the information is out there. If we can piece it together with folks like at this table, I don't think it would be that hard to do. But I appreciate your comments.
Well, I can't tell you how much I appreciate you being here, and I'm sure we're going to run out of time. But let me just say this to you. It's only over when we decide it's over. It's our ability to stick to the message and stick on course and make sure that we fight this to the very end. This is a win for every single American. It does not matter to me how they're registered, by the way. Yep. We can win this battle. The big thing is we just have to refuse to lose. We can win, and we can win for every single American. Thank you all for being here. Chairman, thank you so much.
Mr. Kelly, would you like to submit those statistics for the record?
Yes, I would love to submit them for the record. Thank you.
Without objection.
Thank you.
Thank you, Mr. Kelly. I want to thank the four of you today for spending some time with us. To just piggyback on what Mr. Kelly said, you give us hope. give me hope. These are such important issues, and innovation is a key, I think, to solving this problem, and you guys are on the forefront of that. We've only begun to touch these issues, and we're going to dig deeper into these issues in the future, and I hope you stay in touch with us as we do that. Before we adjourn, not knowing exactly what the calendar looks like the rest of the year, and I'm not in the prediction business, and not knowing then if we might have another hearing or not, I want to take this opportunity to thank Dr. McDermott for, yes, your distinguished service to this Congress over the years, 12 terms to be exact. It has truly been, underline, bold, an adventure working with you. I hope that as you leave this body, that you believe that our disagreements, and there have been many, are heartfelt. I believe that your views are heartfelt, sir. And I also wish you the very best in your next steps. You may.
Mr. Chairman, I didn't know this was my swan song.
It may not be. You may do another one.
I know sometimes you hope it would be my swan song. But it has been a pleasure serving on this committee. When I came to Congress 28 years ago, I made up my mind I was going one place, which was to the Health Subcommittee of the Ways and Means Committee. It took me a while to get there, and then it took me a while to get next to you. But I believe that this area is such a large part of our economy, as well as such a large part of our question of national security and how we take care of Americans, that it is central to making decisions that affect every single American. Leaving the Congress, I don't leave eagerly or glad to get away from it or anything else. I'm sorry I'm not going to stay, because the development that we're talking about here today is going to go on, and it's going faster and faster. When I went to medical school and graduated in '63, the only thing that's left is anatomy. And even that's been changed by now. They're changing so many body parts that it's hardly the medical school I went to. But this committee has the potential for doing more good for the American people than perhaps any other single subcommittee in the Congress.
We agree.
So it's been a pleasure to serve here with you,
Bless
even
you.
though sometimes you're wrong.
I'll let that go. Please be advised that members will have 2 weeks to submit written questions to be answered later in writing. Those questions and your answers will be made part of our formal hearing, as is your testimony. Thank you. With that, the subcommittee stands adjourned.
Thank you.
Great meeting you, sir. Nice work. Appreciate it. For you. Looks like you're doing great stuff up in Appleton and around that area. It's pretty exciting.
Pleasure. Absolutely, I do.
Nice to meet you.
Thank you. Pleasure.
Dr. Long, you're so well spoken, you could practically be a lawyer.
Oh, really? That's right. She's never told me that. Really? For a long time. She's told me that.
You and I will connect up soon. All right. You boy did a good job. I am. How you doing? Thank you. Oh, you're welcome, sir. Great. Thank you. Thank you very much.
Thank you.
Very good. Very, very good. One last quote I wanted you from the